From hyperthyroidism, we go to hypothyroidism now, and we want to talk first about the etiology. And of course, about 95% or even more actually of all the cases of hypothyroidism are primary. It's an organ failure of the thyroid, primary organ failure, and less than 5% of the cases are due to the pituitary, and even a smaller number of these are due to the hypothalamic causes, suprathyroid. So basically 95-97% of all the cases of hypothyroidism is something wrong with the gland itself. If you're talking about medical disease, if you're talking about a disease state that causes hypothyroidism, the most common form that we see in this country is chronic thyroiditis or Hashimoto's thyroiditis. So if they ask you what is the most common cause as a disease, what is the most common disease that causes hypothyroidism, it's Hashimoto's thyroiditis. In this country, we also see another form of hypothyroidism because of the way that we treat hyperthyroidism, toxic nodular goiter, and Graves' disease. One of the most common etiologies of hypothyroidism is post-ablative radioactive iodine ablation that we do in patients to treat Graves' disease and other forms of hyperthyroidism. So right here, the first two cases here, the first two scenarios, chronic thyroiditis and post-ablative, not so much surgery, but radioactive iodine, basically account for about over 90% of the cases that we see in this country of the primary, which are over 95% of all the cases. Then we see some other stuff that are less likely, like drugs. Lithium is a very common cause of hypothyroidism. Amiodarone is another drug that we have to think about. And then even rarer stuff like biosynthetic defects in children, where you have enzymatic deficiencies, or in rare places where there's iodine deficiency, rare parts of the world where there's iodine deficiency. This is very uncommon now because all the salt and all that is saturated with iodine, and basically that we've done away with that. But basically, the most common forms that we see is Hashimoto's thyroiditis and post-ablative radioactive iodine in this country. So what do these patients present with? Well, the classic presentations is cold intolerance, constipation. Some of these patients develop carpal tunnel syndrome. You have to think about this. I told you in acromegaly that when the patient presents with bilateral carpal tunnel syndrome, you have to think about hypothyroidism. You have to think about acromegaly. One of the symptoms that they test us about is pseudodementia. Now, pseudodementia, not real dementia, but they present just like Alzheimer's disease, where the family is complaining that this guy is, not paying the bills, is forgetting things and stuff like that, pseudodementia. And when you see the neurologist evaluate patients for Alzheimer's disease and so forth, one of the first evaluations that they do is they exclude pseudodementia or reversible dementia. They call it reversible dementia, but it's really pseudodementia. And the two things they always exclude is hypothyroidism and B12 deficiency. You have to exclude those before you make the diagnosis of a dementia syndrome like Alzheimer's disease, like Pick's disease, and so forth. So please look for that. Please exclude that. Please exclude thyroid disease as a cause of pseudodementia. They have increased weight, they have dry hair and skin, they may develop a hoarse voice, and now they tell us a couple of other things that they test on the boards. One of the things that they tell us on the exam is that they develop slow, deep tendon reflexes. Now, when you tap on the reflexes, on the knee reflex, right, and the ankle reflex, the upgoing part is normal, right? So the reflex goes up like that normally, and it's the relaxation phase, of the deep tendon reflex that's delayed, that makes you think about the diagnosis. So the slow, deep tendon reflexes is not the whole reflex, but the relaxation phase of the deep tendon reflex that's most consistent with this. Then they tell us also about this last thing about an elevated cholesterol. Now, a lot of people in this country have elevated cholesterol, so it's not a big thing to find elevated cholesterol in people, especially if they're older patients. But this patient, they tell you about a patient that had normal cholesterol up until this time. She's about 65 years old, and all of a sudden now her cholesterol levels, for no reason at all, start to creep up. And one of the things you have to think about is hypothyroidism, making that cholesterol go up, and you have to test for that. So all these symptoms are important, but I want you to pay attention to the bilateral carpal tunnel syndrome. I want you to pay real attention to the dementia, pseudodementia, and please remember the deep tendon relaxation phase, the relaxation phase, and the elevated cholesterol, and think about hypothyroidism. So how do we make the diagnosis? It's very easy. We check a combination of T4, free T4 of course, right? We don't need the T3 that much, and TSH, because 95% of the cases are primary hypothyroidism. We'll get this right here, a free T4 that's decreased, right, and a TSH that's very elevated. That's the typical patient with primary hypothyroidism. That's the most common scenario that we see. And then only in rare cases do we see the other form, right, where it's pituitary, so the free T4 is low, and now the TSH is also low at the same time. Now here in your table, we put this for a purpose. TSH could sometimes be normal in secondary hypothyroidism. It could be normal, but it's normal. It's normal, meaning the levels of it is within normal range, but it's abnormally low with the consistent low 4T4. Remember, when you have a low 4T4, your TSH should always be elevated. So this patient has abnormally normal TSH depending on the low free T4. Now, the other thing that I like that we've put in here for you is that usually patients with suprathyroid, pituitary, or hypothalamic related hypothyroidism, they usually have other related hormone deficiencies. It's very rare to see only isolated TSH deficiency. Very rare, almost unheard of. So what are the things you're going to see? You're going to see growth hormone low. You're going to see FSH and LH to be low, the gonadotropins are low, and sometimes even ACTH is low. Remember, these are all the hormones in the anterior pituitary, and if one is affected, the other ones are affected, and the ones that are affected most likely are the gonadotropins and the GH, and then it's TSH. So you should see abnormalities in those hormones always. People with primary hypothyroidism, there's nothing else going on, right? It's only the free T4 that's decreased here, nothing else. So that's what I want you to remember. So how do we manage these patients? Well, it's very simple. Most people, once they make the diagnosis, they don't do much more. They don't do much more because whether it's Hashimoto's thyroiditis or some other form of hypothyroidism, nobody really cares. What we really do is we treat the patient after we make the diagnosis. So let me say this again. Most of the cases of hypothyroidism, because it doesn't change what you do for this patient, we really don't do more testing other than document hypothyroidism, and then we say, okay, it's likely to be Hashimoto's thyroiditis or some other form of chronic thyroiditis, but it doesn't matter because it doesn't change my management here. What do I have to do? I have to treat hypothyroidism, end of story. How do we treat this? Well, we give them what the main secretory product of the thyroid is. What's the main secretory product? It's T4, so we give them back T4. How long? Lifelong, forever. They should be on T4 every day. The usual doses of an adult is anywhere from 125 micrograms to 200 micrograms a day, most adults. This is the dose that they will need. Some people will need more, some people will need less. Some people will need less than these doses, but it's around this area. We give them enough to make the patient clinically and hormonally euthyroid. So this patient if we're giving him the right amount of medication, let's say his or her medication is about 150 micrograms, this is what you think is the right medication, he or she with 150 micrograms should feel great. They should feel much better than they were feeling before. So clinically, this patient's going to feel good. And then the free T4 and the TSH should be normal. So clinically and biochemically, euthyroid. That's the bottom line. You give them enough or hormones to make them clinically and biochemically euthyroid. Now here's the catch. Once you give them the amount of medication, you should see a normalization of the free T4 within a couple of days, but the TSH levels are going to take about 6 weeks to equilibrate. Please remember this is a very important clinical point. If a patient develops hypothyroidism, once you give them back the thyroid hormones, the TSH takes 6 weeks to equilibrate. Let's say even if you're giving them the right dose, it takes 6 weeks to equilibrate to the amount of thyroid medication you're giving them. So it's going to take 6 weeks for the TSH to come down, even though you're giving them the right dose of thyroid hormones. So please be careful of that. Please also be careful of the rare case if you have suspicion of secondary hypothyroidism, give hydrocortisone along with the thyroid hormones or first, because if this patient has cortisol deficiency, relative adrenal insufficiency, and you give them Synthroid, you give them thyroid hormones and you rev up their metabolism, you'll put them in adrenal crisis. So if you're thinking about secondary hypothyroidism, please give them hydrocortisone along with the thyroxine until you sort things out. This very, very important clinical point. So that's the way we manage patients, and this is lifelong, right? There's no reason to change anything here. They may need more or less later, but basically these patients get on a specific medication, and once you realize what the amount of Synthroid they need to take, or levothyroxine, any form of T4, then what they do is they take this, you know, for the rest of their lives, and they come to your office once or twice a year just to make sure they don't need any change in their dosing. Now, just like thyroid storm, we have the same scenario of hypothyroidism. This is a very severe form of hypothyroidism where these patients have untreated, long-standing disease, where Graves' disease is commonly associated with thyroid storm. Myxedema coma is rare. It's very rare. It really has to happen somebody that's really hasn't been treated for years and years. Because hypothyroidism is relatively benign, these patients really have to be hypothyroid for a long period of time, and then something else, just like with thyroid storm, you have to precipitate this disease, you have to get it worse by some other event. Usually infection is the most common precipitating cause of this, or cold exposure. Some people that are homeless living out in the cold sometimes will develop myxedema coma if they have hypothyroidism because of the cold exposure. So these patients develop stupor, they have confusion, they have altered mental status. One of the characteristic findings is hypothermia. Hypothermia, think about it next time you evaluate in the emergency room or the ICU patients that are hypothermic. Think about myxedema coma and check their TSH levels and their free T4s. The treatment are very high doses of T4, and now this is the first case where I'm telling you to give them T3. Remember, so far I've been telling you when we give back we give any form of thyroid medication, because the major secretory product of the thyroid is T4, we give back T4. One of the exceptions is myxedema coma, because we want this patient to become euthyroid really quick and we need mega doses of thyroid medication. We give them very high amounts of T4, and we give T3 because T3 is a more potent thyroid medication. Just to give you an idea, I told you before an adult gets about 125 micrograms a day of T4, and anywhere from 125 to 200. These patients, if we think they have myxedema coma, we start them off at 300 micrograms of T4. Very high doses of thyroid medications plus T3 to snap them out of that coma, to save them, because this disease also has very high morbidity and mortality. I want to talk next about the thyroidities, these inflammatory processes that involve the thyroid gland, and we're going to talk specifically about two of them, subacute thyroiditis, Decurvens thyroiditis, and then a chronic form of thyroiditis, which is called Hashimoto's thyroiditis. But I want to tell you a little bit, just an overview of these diseases, and they of course are chronic. They involve an inflammatory state of the thyroid. It's an inflammatory state of the thyroid. That's what thyroiditis means. But these diseases fall into one of two groups mainly. One group, the first group, is where you have an acute, intense inflammation. And because you have an acute, intense inflammation, you have spilling of the thyroid hormones, and these patients present with hyperthyroidism. That the typical one is subacute thyroiditis. And because it's acute, it's intense, it usually goes away within a couple of weeks. So acute, intense inflammation goes away without any residual. They present with hyperthyroidism because of the spilling and the damage to the thyroid cells, and you spill out all the thyroid hormones. And the typical one, I said, is subacute thyroiditis. The other one that's typical for this type of thyroiditis is the one that's related to pregnancy, or what is called postpartum thyroiditis. It's the same as Decurvens. It occurs around pregnancy, intense inflammation, and then a couple weeks, months later, it goes away and nothing happens. So acute thyroiditis, but nothing happens in the long run, but you present with hyperthyroidism, or you fall into the second category, where most of these are immune-mediated. So these are basically chronic diseases where you have chronic inflammation of the thyroid, and because you have chronic inflammation of the thyroid, you have eventually, a long-standing inflammation and eventually fibrosis. So these patients with the chronic form, like Hashimoto's, most of the time present with hypothyroidism. So both of these groups are called thyroiditis, but one presents with hyperthyroidism and the disease goes away. The second type presents with hypothyroidism, and it's a form of hypothyroidism that doesn't go away. You basically have to treat the hypothyroidism. So that's the way I want you to think about these diseases. And the first one, the subacute thyroiditis, or what is called Decurvens thyroiditis, or another name for it is giant cell thyroiditis. This is the one that they love to ask on the boards a lot about, because it presents commonly and looks like Graves' disease because it presents with hyperthyroidism, and it's very common, especially in the winter months where viral syndromes are very common. The subacute thyroiditis, again, falls into the category of acute inflammation that goes away and doesn't return after it goes away. So it's usually viral origin. You get a viral inflammation, viral infection of the thyroid gland. The patient presents with hyperthyroidism, so they have the tremor, the palpitations, the weight loss, maybe the diarrhea, and the tip-off is on the exam. The patient says, I have thyroid pain. When you feel the thyroid gland, the patient, kind of jumps back because it's very painful. The patient has thyroid pain. Sometimes I've had patients, they come to me where they present of neck pain and lower jaw pain, and tremor. And they say, I got this vague pain around this area, doctor, and I have tremor and some diarrhea and stuff like that. Because it's an intense inflammatory state, the erythrocyte sedimentation rate is always elevated. If they ask you on the boards, what is the lab test that's associated with Decurvens thyroiditis, the answer is an elevated erythrocyte sedimentation rate. I mean, beyond the T3 and T4. So an elevated sed rate is always the case with this disease. And initially, I'm going to show you in a slide in a little bit, initially, because of the damage to the thyroid cells from the inflammation. You have the breakdown of the thyroid cells, spilling of the thyroid hormones. Patient presents with hyperthyroidism, right? And then if you, at that point, do a radioactive iodine uptake scan, you're going to see decreased uptake because the damage of the cells. They don't uptake any radioactive iodine. If you look at this case, this is your free T4 right here. Your free T4, right? And this is your thyroglobulin along with that, because remember, once you secrete T4 and T3, your thyroglobulin goes up. So look at this. The patient comes in with hyperthyroidism. This is your free T4 and free T3. They're calling it here free thyroxine index, but it's the same thing. Free T4 and free T3. You'll know it for the boards as a free T4, free T3. It's elevated, right? The thyroglobulin level is elevated. Now look at your TSH here. It's suppressed right here. Here's your TSH. And what happens after about a couple of weeks or a month, look what happens now. Now the thyroid hormones come down a little bit. In fact, they dip into the hypothyroid state, and then they eventually bounce back to normal. So that's the bottom line, that these patients eventually are hyperthyroid, and then they dip down into hypothyroid state a little bit until the thyroid gland rejuvenates itself, and then they have normal thyroid function. Now here's the thing. If you make the wrong diagnosis and you basically think this patient has Graves' disease or toxic nodular goiter, and you start to treat the patient with propranolol and PTU and stuff like that, now you're going to make this patient here really hypothyroid. So that's why they want you to know this disease, because if you misdiagnose it and you think the patient has Graves' disease or some other form of primary hyperthyroidism, and you give them PTU, they will eventually become severely hypothyroid. And they won't bounce back here. I mean, they will after you realize what you've done, but they want you to make sure you don't make the wrong diagnosis here. It's very, very important. So subacute thyroiditis presents as hyperthyroidism. The thyroid hormones dip down into the subnormal range, and then they go back to normal range, a couple of weeks, a month later. So let's go back here. So how do we treat these patients? How do we treat them? Well, it's only symptomatic treatment. We give them, the ASA here is for aspirin. We give them aspirin and non-steroidals, pain medication and anti-inflammatory medications. That's what we give them. Some people say give them a little bit of prednisone to decrease the inflammation, but most of the times aspirin and non-steroidal anti-inflammatory medications are good enough. Most people don't have to give prednisone. Some people say if a patient has severe palpitations, I had a patient like that where she couldn't read, she couldn't take examinations because so much palpitations from the hyperthyroid state, you could give them low doses of propranolol to suppress, right, the symptoms, but not anti-thyroid medication, or you'll make them hypothyroid. So aspirin, non-steroidals, maybe prednisone, maybe patients with severe palpitations, maybe a little bit of beta blockers, but that's it. Only symptomatic treatment until the patient becomes euthyroid. So the bottom line, this disease eventually subsides here. You don't have to do anything more, just make the right diagnosis. How do you make the right diagnosis? Do the radioactive iodine uptake scan, which shows a decreased uptake in these patients. The second form of thyroiditis that I told you about that we have to know involves a chronic thyroiditis. Now this is not acute. So this doesn't, come on really quick. It doesn't destroy the cells and cause hyperthyroidism initially, but there's chronic inflammation over a long period of time, months, maybe years, and these patients, after chronic inflammation and lymphatic infiltration, that's what you see if you biopsy patients with Hashimoto's thyroiditis, although we rarely have to do that. We usually don't do that. But if you biopsy, you find lymphatic infiltration, lymphatic cell infiltration of the area. So what happens is chronic inflammation, lymphatic infiltration, and then fibrosis eventually over a long period of time. And these patients present with hypothyroidism when they come to us. Now this is an autoimmune disease. You find anti-thyroglobulin antibodies. You may find antimicrosomal antibodies. There's a lot of antibodies that these patients have, and because they're autoimmune diseases, Hashimoto's thyroiditis is, they develop other autoimmune diseases like pernicious anemia, like myasthenia gravis, like diabetes mellitus, and so forth. What do we find? Maybe we find a rubbery goiter. We find maybe a non-symmetrical goiter because not all the areas are fibrosed. So the areas that are working normally, what happens is they become bigger than the other areas that are fibrosed because they're trying to basically produce more hormones and make up for the other area that's not working well. And then eventually they come to us with hypothyroidism. Now people ask me, they always ask me, is it hypothyroidism that they present with Hashimoto's thyroiditis? The answer is yes. The most common manifestation to the physician of Hashimoto's thyroiditis is eventually hypothyroidism. Yes, in rare cases, you may have in the initial course of the disease a mild hyperthyroid state, like subacute thyroiditis, but it's very mild. It's not fulminant like subacute thyroiditis, so they don't usually come to the physician. It's very mild, a very mild form of hyperthyroidism. Some people refer to it as Hashimoto's toxicosis or Hashitoxicosis, but for your purpose, that is rare. The patient usually doesn't come to the doctor because it's so mild. They usually come to the physician months later or years later, usually with hypothyroidism. So the diagnosis is made through the hypothyroidism plus finding antimicrosomal antibodies. This clinches the diagnosis. Now, do you have to do this? The answer is no. Most people that we diagnose with hypothyroidism, we say, okay, it's likely Hashimoto's thyroiditis. We don't have to do anything more. Some people like to document it because these people have other autoimmune diseases, because these patients are asking other questions about what's the cause of my disease, so they may want to get antimicrosomal antibodies, but it's not necessary because it doesn't change what you do for this patient. You don't have to do a thyroid biopsy. I said you find lymphocytic infiltration, if you do the biopsy, but you don't have to do the biopsy because it makes no difference. Once you diagnose this disease, what you do is after this, you treat it with thyroxine T4 for the rest of the patient's life, and you don't do anything more. Commonly, they ask us about Hashimoto's thyroiditis. They tell us that years later, this patient has some kind of other disease. Look for other autoimmune diseases like pernicious anemia, B12 deficiency and pernicious anemia, right? Myasthenia gravis, diabetes, other autoimmune disease, vitiligo is very common in Hashimoto's thyroiditis, and so forth.